It's my great pleasure to join you today as part of the ePCR course as a result of the extraordinary COVID situation that we're all experiencing. We're here today to discuss how to treat bifurcation lesions from bench to being. And this is kindly sponsored by Terumo. These are my conflicts. The objectives for today's session are to consider the best treatment options for patients presenting with bifurcation lesions, to utilize bench simulation in testing bifurcation techniques, and then to learn, hopefully, from masters how to optimize decision-making in this complex setting, to consider the techniques that we should use to offer patients their best outcome. So it's really a great pleasure to be here, albeit in Bristol from my part, but to join Thierry, Lefevre and Bernard Chevalier in Massy, Paris, to walk through, hopefully, a case of bifurcation lesion together, and then also to utilize their expertise in terms of bench simulation to gain a better understanding and grasp of the bifurcation techniques. So I'd like to hand over to Bernard and Thierry now.
Thank you very much, Tom. It's also a pleasure to be part of this ePCR session. It's really something new for us, but we'll try to do our best. So Bernard will be the first operator. I will show you the story of the patient. And we have also Sophie as a nurse and Maud outside of the cath lab. So we have this young woman of 87 years old. For this case, she was admitted last week for unstable angina. She's in very good shape, and she had the typical chest pain for 30 minutes and was admitted in the intensive care unit, the coronary care unit, 1 hour later. You can see she's 160 centimeters, the weight 70 kilograms, BMI a little bit high. She had no previous cardiac history, only gastric ulcer years ago, and some asthma on treatment. Risk factors, only hypertension on beta blockers and amlodipine. She had also indapamide and Symbicort for his asthma. If you look at the laboratory investigation, you can see that after admission, troponin T increased from 53 on admission to 1,300 nanograms per liter. CK elevation was relatively low. She had some elevation of pro-BNP and pro-BNP, and the creatinine was little bit low, as usually in this old patient, with a clearance of 45. Hemoglobin is normal, leukocyte normal, and cholesterol close to normal. This is the baseline and EKG, and few hours later EKG. You can see that there was some modification in the inferolateral territory, but also in the anterior territory. The echo was done the same day, and she had some hypertrophy of the left ventricle, as you can see, probably due to old hypertension. Ejection fraction was normal, and there was no other abnormalities. So this is the first angiogram on the areocaudal view. You can see that there is a tight stenosis of the mid-circ, relatively short, and the tight stenosis of the bifurcation between LAD and diagonal. We'll see on the next slide the bifurcation of the LAD diagonal with a lesion which looks not so severe in this view, but as you have seen before, it was relatively severe. And the lesion is relatively long with a reference of the vessel which is not big, as around 2.25 millimeter. In the LAD and diagonal. This is another view which is a little bit better for seeing the lesion of the LAD. This is a LAO view showing the tight stenosis of the circ. And the right is codominant, right, which is with some disease, but no significant disease. Okay, so in summary, we have an 87-year-old female. She will be 88 in a few days. She had hypertension, good left ventricular function with hypertrophy. She had a non-STEMI with dynamic EKG changes and elevated troponin, bifurcation of LED diagonal, Medina 111, and 90% circumflex, mid-circumflex. So of course, we had a discussion at that time, and the majority of people thought that the culprit lesion of this unstable angina was a circ, and the circ was treated immediately on the table, and the treatment of LED diagonal was postponed for today. So you have seen the result, and now we have to treat this lesion. I have to say that 3 days before today, the patient was readmitted for angina. It was not unstable, but she had residual angina, which was related to the LED diagonal bifurcation. And we were discussing with Bernard if we have to do ischemic testing in the LED diagonal, but now we are convinced that this lesion is really critical with this residual angina.
And we have also negative T waves in anterior.
Yeah, so EKG today is a little bit different with more modification in the LED territory. Can we go back to the angio? Yeah. So we have to discuss about this lesion, the strategy. Maybe Tom, you can help us.
Well, Thierry, it's interesting to hear that over the course of the last week, the patient's been readmitted with chest pain, because certainly when we first discussed this case, and I'm sure there are differences across all the territories of the PCR community. In the UK, this lady probably would have been discharged home with a plan for medical therapy for her bystander disease. But I think the presentation with further pain, with the T-wave changes we've seen quite clearly across the anterolateral territory, and the fact she maintains an active lifestyle, absolutely justify then the intervention to this bifurcation lesion. And then I guess in terms of a pragmatic approach and knowing the Massey approach, then really you're wanting to maintain a provisional approach if possible to this bifurcation. You know, we've talked about her previous history of a gastric ulcer, wanting to limit the potential downstream complications in terms of antiplatelet pharmacology, bleeding risk in an elderly patient with some renal impairment. But then from a technical perspective, the one element I think that's most important that you've already highlighted is this discrepancy in caliber from the proximal to the distal vessel, which also has to be taken into consideration here. So I would get a provisional approach. The disease in the ostium of the diagonal clearly needs protection with a wire in my practice, but I guess I'd hand over to you really in terms of what you're intending technically.
Maybe we can show the image of today.
Yeah. So we fully agree with you.
Live.
Bernard has already put a run-through wire in the LED. We have extra backup 3.56 French. And now we will come with a second wire, another run-through in the diagonal. And we take the time to measure the length of this LED lesion in order to select the optimal stent. Okay.
I think we are more or less where we
we can make a movie like that if you want. Yeah.
Okay, we can make an angio like this.
Okay. So the radio opaque part of the wire is 30 millimeter. We plan to cover from the LED up to the proximal lesion.
I think the distal tip of this wire is approximately where we plan to land.
Yeah, so 28 will be okay?
I think 28 should be okay because we have some room in proximal part.
I agree. Okay.
So I will keep the strategy of 28.
Yeah, I fully agree.
Yeah. I think it's
so we'll select Ultimaster.
Let's see, master
225,
225.
28.
With that degree of calcification and having just pre-dilated with a 2 millimeter balloon proximally, would you consider taking a larger balloon just to ensure expansion? Or you're happy?
It was a 225, so it's not perfect, but we went to 20 atmosphere with very little residual waste. So I think we'll deploy the 225 and then do the pot, and we'll select a non-compliant balloon for the pot so we can go to higher pressure.
But I think another aspect, particularly in relation to this optimise device,
the calcification.
Yes, I think it's great. Distally is great.
Okay.
Proximally, of course, we have to do the pop, but distally is great.
Yeah, and you see the calcification a lot. There is a big line of calcification just proximal to the diagonal.
Yeah.
Okay, so now we can do the pot, and we'll do a stent boost again after pot, yes. I think. If you agree that the LED is 225 and diagonal is 225, then you multiply by 2, so it's 4.5. 225 is 4.5, multiply by 2 is 9, divide by 3, it's 3. So the theoretical diameter should be around 3 millimeter, proximal to the bifurcation. So that's why we selected the 3.0 non-compliant.
Good, and I think it's important to understand that the different stent manufacturers have different expansion capacities,
yeah, absolutely,
amongst their mates. It really is impressive that this 2.25, if needed, could expand to 4.5.
Yes.
Which is by far and away the largest expansion profile that a small vessel stent can provide.
Yeah, so I think it's
again, the decision making, that issue of ensuring you have adequate length proximal to the bifurcation for your pot, and to have considered how big that stent needs to go, are the two essential elements to choosing your stent at the point of preparing the bifurcation. Yeah,
Tom, I think it's a very important point. So of course, we select the stent according to the distal reference, but also to the capacity, expansion capability of the stent, which is also very important. In this case, the 225 design of the stent is the same as the 3.0.
Okay.
So it's in fact a 3.0 stent. So I think it's not an issue.
Just we check your position.
Yeah. Of course, we pay attention to the position of the balloon. Okay. So you pushed a little bit, Bernard, during the injection. Huh? Yes. So what we want is to have the distal part of the balloon exactly at the level of the carena in order to push the stent proximal to the carena.
And it's always behind or beyond the divergence of the wire.
Absolutely.
Because the wire is pushed away by the...
Yeah. Okay.
Bernard, that's a really important point that you make, that often the jailed wire is used as the landmark, and in fact it is never accurate because it's placed on the outer wall of the bifurcation. So you're placing that distal marker onto the carena, right?
Yes.
Yeah,
that's right.
So 14.
14 is okay.
14, it's 3.04. You like it?
Yeah. Okay. And now we are going back to stent boost.
Yeah.
To check that. Sorry. Up.
And we'll see the different diameters of the stent, proximal and distal to the bifurcation.
Okay.
Oh. It's nice.
Okay. This version of stent boost is interesting because usually we are confused by the radio-opaque part of the wire, but here it's well visualized.
Yeah.
Nice expansion of the stent into the bifurcation.
Okay. So the result on the ostium of the diagonal is still the same.
Yeah.
So no modification. So I think it's very nice. I'm convinced that many people will stop at this level, but because the diagonal is big, we think that it's better to open the strut toward this diagonal.
Okay, so I will try to exchange the wire.
So clearly the diagonal ostium is looking very good, isn't it? And you mentioned many people would stop. It's your practice to keep most bifurcation.
No, not most, but in this case, the diagonal is as important as the LED in this patient. So
okay,
we think it's better to correct the and to improve the flow in this diagonal. At least the rheology in the diagonal.
Yeah, for sure.
I think I need to reshape this one.
Yeah, probably. Yeah. Okay. So we see that there is some pinching of the diagonal, but it's very acceptable. Huh? So we can anticipate that we'll have a nice result with only one stent.
Yeah.
Not 100%, but more than 80%, I think. Yeah.
Do you have any particular tips or tricks in terms of wire shaping for recross? Is there anything you do in particular to?
I did a little bit secondary curve.
Yeah.
Yeah.
To be sure that.
So one thing which can be very useful is the pullback technique. So putting the wire in the LED and then by pulling back, jumping in the diagonal.
Yeah.
So sometimes it's very useful.
And you're aiming for a distal cross, right? As distal.
Yeah, absolutely.
As much as possible, yes.
Yeah.
And again, in theory, and perhaps we'll see this on the benchtop, the very open cell nature to this Ultimaster platform hopefully enhances that chance combined with the pop, but with just two linkers per rotation gives a very open cell structure.
Yeah. Okay, so I think we have a good separation of both branches in this view. And we can see the tight stenosis that we have at the ostium of the diagonal branch. So I think this can be a good working view to access the side branch.
Yeah.
A really nice demonstration of how we were fooled in the view we felt was so helpful.
Absolutely.
Great.
Yeah.
So you just see it interacting.
Okay.
This one is okay.
Thank you, Bernard. Very nice.
Well done. Great.
Yeah. Petit test. Okay. Okay. Perfect.
Okay, so we do another pot.
So in order to solve this issue of difficult diagonal access, we'll do another pot and move to hydrophilic wire, a feeder FC. Okay, so Bernard has made this tip in order to access the diagonal with a feeder FC, because we had so many difficulties to wire how to cross the strut with a balloon.
Yeah.
And we try to find another strut.
Yes, yeah. Okay, this one is easier, yes.
That certainly looked easier than the previous one.
Yeah.
Yes. Yes, this kind of wire, of course, has a lot of
okay, so 1-0.
glide, so it's very easy to.
Mm-hmm. So will you go straight back to an anchor, or you try again?
I think we'll try again.
Try again without anchoring?
Yes, I think so.
Okay.
Maybe we cross a different struts.
And we have done another pot, so
you have to give us this chance.
Okay. So you see probably different struts, or maybe the second pot was very useful. Okay, je dis là?
Yes.
Okay, so you see it's a very short balloon, right? So it's 5 millimeter in length.
Maybe I suggest to go a little bit more distant, proximal.
Proximal,
sorry,
yes.
To be sure that we are
Yeah.
opening, yes.
I think that's right. It's only in that caudal projection, isn't it, that you get a true feeling of the ostium.
Yeah.
Yes.
Petit coussinet.
Yes.
Okay.
Deflation.
Did you feel some resistance when crossing? No. Okay.
Not at all.
Okay. So now we use 225/8 for the diagonal and 225/15 for the LED. Mm-hmm.
Yes. Okay. That's not so bad, no?
Yeah. Maybe the diagonal a little bit.
A little bit more proximal.
Yeah. Diagonal is this one, no?
Okay.
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 Oh, yeah, it's good.
Like this. And I will pull a little bit this one. Okay.
So we see nicely that interaction, one balloon forward and backwards.
Yeah, absolutely.
Yeah, I think it's okay.
So we go to first one.
To diagonal.
So low pressure.
Low pressure, yes. Just nominal, no more.
So we'll do a stand boost, which will give us some information about the result.
Yeah.
Mm-hmm. So we clearly see that there is 2 diameters.
Revient normal.
And the stent is well open. There is still some waste on the stent at the level of the calcification, but I think it's very acceptable.
Yeah.
So if we are back to what we had at the beginning in the diagonal, I think it's acceptable because we have opened the strut. Probably it will be better, but except if we have some dissection, we'll see.
On va faire un angio?
Ah, it's nice.
Very good.
So you see in this view, we have something very nice. Maybe we can do another one.
I suggest to check the PA caudal we did.
Yeah, absolutely. Yeah, so I think it's very nice result. We have already done a good pot up to the proximal part of the stent.
Yeah, we did 2 pots.
2 pots, distally. Now the kissing was done with a very nice result in both branches. Yeah, so I think it's good.
A very nice demonstration of a kind of safe and stepwise approach to a bifurcation that proved more challenging than it looked initially, I think. It showed beautifully the importance of the pot.
And absolutely.
The sequential approach to opening up the side branch was very nicely demonstrated. So the importance of wire curve, the consideration for a different type of wire characteristic, how useful that second pot to reconform the side branch ostium was really impressive. So no, great result.
Okay, thank you very much, Tom, for your support and the discussion that we had with this case, which was relatively difficult in terms of side branch access,
yes,
but with the end of a very good result. So thank you very much. I hope that it was helpful, and we try to explain what we have done in the bench. So we'll see if it adds more information.
Fantastic. We'll look forward to
that. Thank you very much.
So that was a fabulous demonstration of the provisional approach. And I think what was most useful was to actually see the challenges of clinical reality. And so we saw the importance of understanding expansion property of a stent and the need to optimize around the side branch. And so it's important to understand the Ultimaster design offers this uniform scaffolding, so gives coverage of the bifurcation anatomy, but then the open cell two-link design gives then the opportunity to open cells into the side branch. So we can then see that having reopened into the side branch and considered this discrepancy of size, proximal and distal, that actually having a stent that can expand from 2.25 to 4.5, or in the large vessel, the 3540 stent up to 5.8, clearly offers advantages in challenging lesion subsets. Now, the drug coating then, unique to the Ultimaster, has polymer coating just on the long lengths of the crown and not at the hinge points. And so this overexpansion, there's always a concern that you might disrupt the integrity of the polymer. But here, due to the unique design, we can be confident that the drug will elute from the polymer surface just along the long length portions of the crown design of the Ultimaster. And so here we see a really nice benchtop example of the stent, both small vessel and large vessel, overexpanded from this 2.25 stent that we used in the case today, having the potential to expand to 4.5. And as I've said, the 3540 platforms being able to off-label expand up to 5.8 millimeters. And so hopefully with the benchtop simulation, we'll see very nicely this expansile property, and then hopefully be able to recreate the challenges that were encountered, particularly in terms of wire cross and the relationship of the wire with the stent struts, and then also the passage of a balloon and seeing how the nose cone can potentially interact with the stent itself. And so it is worth recognizing, as we discussed during the case, that the balloon design does have some impact on what we aim to achieve. And the AccuForce has now been designed with this shortened, rounded shape, both at the proximal and the distal edge of the balloon, which is particularly useful when considering our pot and post-dilatation of the stent. So trying to minimize really any potential injury distal to the stent, and then most importantly during the pot, not wanting to distort the true carina with then potential impingement or narrowing of the side branch ostium. So again, hopefully by simulation, we will be able to demonstrate these key features, both of the balloon and stent design. So with that, we'll hand over to Thierry to demonstrate the educational benefit of the benchtop simulations. Thierry.
So we'll try to simulate what we have done in the patient, in the bench, with the help of the Terumo team, who build a very nice bench for simulating bifurcation treatment in a silicone model. The anatomy is very close to what we have done just before, with LED, which is a little bit bigger, 2.5, and diagonal branch, which is 225, and the proximal is 3.0. You can see that there is some stenosis, but which are not very severe. So usually we wire both branches. You can see that I have already done some angulation. In the previous case, we went to the LED, but my recommendation is to start with the most difficult, which is the side branch. So this is a run-through wire. I use the second one. Okay, so now I'm coming with a wire, so very similar shape. And you can see that we can go in the LED. So we have selected a 2.5 28 millimeter Ultimaster stent. In the patient, it was 225. And of course, we have to leave some space in order to be able to do a good pot proximal to the bifurcation. Okay. Okay, so we can go up to a nominal pressure. So of course we can see a discrepancy between the proximal part of the stent and the distal one. So that's why pot is very important. You can see also that the wire in the side branch is not close to the carena, but proximal to the carena. So it's not a good good information if you want to go through a distal strut.
The console, the OFDI console has the most incredible capacity to alter the length and speed of pullback, so you can get very high resolution imaging. It's
Absolutely.
All I can't quite see what the settings are set at. Super.
Okay, so you have seen the malaposition very clearly. Can we go to a full screen for the, yeah, okay. So you see the stent well opposed distally, the bifurcation with a lot of strut in front of the side branch, and then malaposition proximally all along the LAD, which was not visible in the screen, in fact. So I think it's a very nice demonstration that if you put a stent, don't do a pot, you do something which is not optimal. Okay, so now we have a 3D reconstruction coming, full screen.
Very good. It does show a lot of strut, doesn't it, across the side branch?
Yeah, absolutely.
So
you can see, yeah.
The linker, there is a linker which is just being overlaid by the jailed wire.
Yeah. So this is this is exactly what we had before doing the kissing bone inflation in the patient. So a lot of struts in front of the side branch, which is a problem in terms of rheology. So formation of thrombus just behind the strut. Areas of recirculation, etc., etc. So I think it's very nice. Okay, so it looks a relatively good position. I went to 14 atmosphere. Of course, it's also very important to do the pot up to the proximal part of the stent. See. So I went to 14 again.
You see the very proximal edge of the stent just being pulled in by the balloon, don't you? It's quite revealing when you look at it on the bench.
Yeah. I will try to do it again. Yeah, okay. So now we have better results. This study, of course, is the same, but in front of the side branch, it's clearly better. Malaposition, there is still some malaposition, but not too much. Okay, so now we see clearly the two diameters, distal to the bifurcation, proximal, and in front of the side branch, you can see that there is less strut in front of the side branch, just because we have enlarged the stent proximal to the carena. So it's very nice. So it's nice because you see, if you go from the up front, you are going in the proximal one. If you go from distal with a pullback technique, you go in the distal one. Okay, so I think this one is good.
Very nice. It's beautifully recreating the images we had in that caudal projection of the wire.
Yeah, exactly.
And it's important to note that, albeit this is a model, but that's the point at which, you know, dissecting a side branch becomes a real concern, and so there has to be care with the wire.
Yeah. Yeah, this is why we usually do not do any predilatation in the side branch, because you create some dissection and you may increase the difficulty.
Nice.
Okay, so this side branch is not so easy. So what we can do is just to, you see now I'm pulling back the gel wire, and you see the attraction of the guiding catheter just by pulling back the wires. So this is what we call the left hand control. So with the left hand, you are able to pull back the guiding catheter when you have this kind of attraction.
Very nice.
Okay. Because of the gel wire.
And that's really important, because had that been
okay.
an osteal position, then the chance of deforming that stent would have been incredibly high.
Okay, so we'll inflate the balloon in the side branch. Usually we do the kiss at the same time, but I just want to show the deformation of the stent when you inflate in the side branch. Okay.
Very nice.
So you can see now that we have some scaffolding of side branch ostium, despite it's close to a T-shaped angulation, and of course attraction of the struts on the opposite part of the LAD, which of course should be corrected by something. So it could be pot side pot. You see that there is also some recoil, or kissing bone inflation. So we like to do asymmetrical inflation, but deflation at the same time. I think it's very important. So usually we inflate the side branch first. Donc d'abord moi. Okay. You see the deformation. Now the main branch. Okay. Correction of the deformation.
And then look as
we can go to 14 both. And you see now that we have very nice scaffolding of the ostium, the diagonal branch. And if needed, we can do a T stenting. In fact, tap will not be necessary in this case, because we went through a relatively distal strut and we have a very nice scaffolding perpendicular to the origin of the diagonal. Okay, deflation.
There's been a lot of recent commentary about repot and being slightly more proximal so as not to disrupt the work that you've achieved with the KISS, isn't there?
Yeah, so that's why I'm just proximal to the polygon of confluence. And we can go to, so it's a semi-compliant balloon.
Is that just because of the silicon nature of this? Ordinarily you'd use a non-compliant, or you have?
It depends. If the vessel is calcified, usually I use non-compliant just to be sure that the stent will be fully open. But in this case, semi-compliant is perfect. And you can also adjust the size according to the pressure that you are using in order to be sure that the stent is really fully deployed. So it was a 3015. So now we have corrected this deformation with the proximal pot up to the proximal part of the stent. And maybe we can do the final OFDI pullback. Okay, so now we have seen that we have a full apposition of the stent strut everywhere, distal to the bifurcation. Now proximal to the bifurcation.
Very good.
Okay, so good apposition everywhere. And we look at the 3D now to see how it is exactly.
Again, it shows very nice stent coverage. Fantastic.
Yeah.
And you see again how that stent has expanded out onto the outer wall into the low shear area of the bifurcation. Very good. Beautiful, Thierry.
Thank you.
C'est magnifique. So I hope you agree that this combination of simulation-based bifurcation teaching and the use of a case has offered insights that we might not ordinarily have available. Thierry and Bernard have given us a really great example of a stepwise approach to a bifurcation that initially seemed straightforward with a provisional approach, but actually proved to be very challenging due to the difficulties that were encountered with side branch access. But we've seen through that challenge the importance of a dedicated approach and the treatment options available to us through the bifurcation strategy, and particularly the importance of proximal optimization, and in fact a further proximal optimization to enhance side branch access. How critically important it is that we use more than one angiographic plane to get an understanding of the true bifurcation. And then through both a combination of the case and Thierry's simulation, we hopefully have grappled with a better understanding of how the stent characteristics, the design of the balloon can influence our, or certainly enhance our chance of an optimal outcome for the patient. I would really like to emphasize that stepwise and safe approach to undertaking bifurcation, whether on face value it's a provisional or a complex two-stent approach that we're adopting. And with that really, and through this fantastic platform that's evolved through the COVID crisis, I'd just like to thank both EPCR and particularly Terumo for their support in this session. Thank you for joining us.